Okay, good morning, everyone, and welcome to the Pay for Value Impact Series with the Department of Health focused on the Rural Health Transformation Program. I'm going to wait just a few minutes to let everyone log into the webinar. I can see people trickling in right now, so I'm going to give it just a little bit longer, a few seconds here. I think I said this in yesterday's webinar, but it is sunny here in Anchorage. We're enjoying the bright sunshine. I don't know if it's still snowing in Juneau. If it is, I'm sorry. I hope the snow ends soon and you get to experience spring. And I don't know what it's like around the rest of the state, but I hope wherever you're at, you get a little ray of sunshine. It's a nice way to start off the day. Okay, so if you have joined us, you may have participated in some of these series before, and I see the sun is out in Ketchikan, so at least someone and Juneau, so Southeast is getting sunshine too. Well, that bodes well for today. So it looks like we're all getting a little ray of sunshine somewhere. But if this is your first Impact series, the Department of Health is hosting a series of what we call Impact series, and they're really focusing on the Rural Health Transformation Program, building partnership, spending time digging in a little deeper into these different topics, just so that as a state and as providers and patients and policymakers, we can start to think a little bit differently and more deeply about some of the different topics within our Rural Health Transformation Program. As part of Alaska's Rural Health Transformation Program, we have about 6 different proposed fund use initiatives. And for those of you who have heard us talk about those before, you're probably sick of it. You can go on our website. We'll give you information about that at the end of the webinar. But this Impact series focuses on one of those initiatives called Pay for Value. So how do we develop fiscal sustainability, and how do we start to align the outcomes that we want to see in our system with the way that we are paying for healthcare? So today, I appreciate you joining us for the next hour. We are going to complete our welcome here pretty soon, provide a review of the impacts for the Rural Health Transformation Program and how to think about these series. Talk a little bit about kind of an introduction in terms of pay for value. What does that mean? How should we be thinking about it? Kind of, again, set that direction and then look ahead. So thanks for spending the next, I don't know, 56 minutes with us. Next slide. So today's panelists include Commissioner Hedberg, who's here. Hi, Commissioner. Myself, I am remiss in introducing myself. My name is Emily Ricci. I am the Deputy Commissioner in the Department of Health. And then we have Dr. Lisa Rabinowitz, who's an emergency medicine physician here in state. And I believe we are also joined by Dr. Ann Zink, who probably does not need an introduction. She's also an emergency medicine physician, but does a lot of work with the Yale School of Public Health as well as Zinkwise Consulting. So we're really excited to have both of them leading this session. Before we kind of kick off and I hand it over to them, I just want to acknowledge that pay for value, out of all of the initiatives that we're looking at in the Rural Health Transformation Program, I think pay for value is one of the most important because it supports healthcare access, it supports our workers, it supports our technology, but it's also a way for us to think about how we want to shape the system, right? How can we start to build a system that aligns how we pay with the outcomes that we want to see? How do we start to identify ways where everyone participating in the system has similar incentives, right? Because we're all reacting to the different incentives that drive our business decisions, our policy decisions, our budgetary considerations, or where we seek care. And I also just want to acknowledge that this is really hard. And I think there's a lot of different room for what may work for one type of care or service or provider may look different than others. At the same time, it's really hard to build out a lot of different systems. So I think as Alaska begins or continues to walk down this road, we have some good examples in state, we have examples out of state. But ultimately, when we think about the healthcare delivery system in Alaska, We have really different systems within our state. We have the tribal health system, which operates in a very different financing framework than the rest of the healthcare system. And so as we think about pay for value, I think initially a lot of what we think about is focused on kind of voluntary participation in the kind of more standard medical system, not necessarily the tribal system. But as these discussions progress, it's going to be really important for us to kind of acknowledge where we're at, where we want to go, and how do we get there working together. So with that, I will pause and pass this over to the panelists for the rest of the presentation.
Perfect. And thank you, Deputy Commissioner Ricci, for those thoughts and for starting us off. Thanks to the whole DOH team for creating this space where we can kind of explore pay for value today. We're really excited to continue exploring this. We saved the best for last. Pay for value, as Deputy Commissioner mentioned, is one of our ways that we can really create innovation and impact with our health systems in Alaska. So thanks to all of you also for joining us again for another exciting impact session. I want to also acknowledge all the great work that's already being done around the state, improving health systems and also demonstrating value. We want to brainstorm today, figure out how we can broaden our impact. Collaboration is key as we keep discussing. So many of you are already putting your contact information in the chat. Please tell us a little bit about yourself, your organization, what you're hoping to advance with the funding, and put in your email, your phone number, so collaboration and synergy can happen in the webinar and outside the webinar. We want to continue these conversations. And next slide, please. So the Department of Health has worked really hard to make a transparent process for this rural health transformation. Many helpful resources. I want to encourage everyone to go on the website. It has a ton of great information. They're updating it all the time, so I'm constantly going back on there to see what new information is available. There are also office hours for technical assistance, really around the application process itself. And then stay tuned for the in-person regional planning meetings. These are coming up soon. Our first ones will be towards the end of April, and we're really excited to dive in and gather community input on the unique needs of each region. And last week, we started our impact sessions, and these are designed to explore the 6 initiatives or focus areas that Department of Health has identified after feedback from all of you and communities across Alaska, and really forming how the funding will be dispersed and how we can think big and transform our system. So today is our last inaugural impact session. Again, I said we saved the best for last, pay for value. And next slide. So these impact sessions are really meant to be interactive. We want it to be more forum driven, guided by the state priorities, but also all of you and your participant recommendations. So we'll have some polls today. It's important to note that your organization may cross over in many of these impact sessions. So please feel free to go to as many that align with your project. And really apply to your vision. This is how collaboration is going to happen. This is how we're going to connect and make this exchange of ideas really blossom into something even bigger. And we want to just remind people that these impact sessions are not a way to vet your projects. Dr. Zink and myself have no stake or role in determining which projects are funded. And so we want to really just think big in these sessions and brainstorm together and work hard on that. And next slide, please. What these sessions really are, again, is about connecting. And this does include tech experts and vendors, including data, payment modules, things like that, that could apply to our pay for value today. We want to foster collaborative learning and information exchange, again, through a forum that allows us to kind of have back and forth. Let's discuss this and keep it open. Building a shared vision for transformation. This is our chance. This is a huge opportunity to decide what rural health systems in Alaska look like, sparking innovative thinking and encouraging us to kind of reimagine what this looks like. And again, we keep promoting partnership, collaboration. That's where it's really at. And next slide, please. I'm going to throw this over to Dr. Zink, who's going to give us an overview of the Rural Health Transformation Program.
Yes, hello to sunny Alaska across this great state. It's wonderful to see new faces on here, reconnect with old. As many have seen, this is, if you've been on other webinars, similar, but the end of this is going to be different. So just highlighting, I feel like really lucky to have both Commissioner Hedberg and Deputy Commissioner Ricci being here as we think about this, because really to make this sustainable, we have to be thinking of value. So I want us to be thinking about both of those things in the same kind of breath. What are the kind of the steps that are needed so that we can take this one-time $50 billion across the country funding that then got allocated to the state in a one-year funding of $272 million that needs to be allocated between January and October for something that is long-term and sustainable. And we know that all of healthcare cannot be transformed in a 56-day application the team put in, but it can be transformed by all of us working together and thinking about how do we want to make sure that each dollar that is being spent is really focusing on the health and well-being of Alaskans. So if you go to the next slide, this highlights again the phased approach of the process. So, I've heard a lot of feedback from clinicians and health systems. We can't do this in 1 year. This isn't a 1 year thing. This is 5 years. So you get to think about what you want to do in year one that can lead to year two and therefore move out so that your brilliant ideas are sustainable and that they are consistent in the way that we are able to pay for value and using each dollar as well as we possibly can moving forward. These series are called impact series because that's what they're hoped to be, to have impact on the ways that our system is being transformed. And we have this really unique, honestly, once in a lifetime opportunity to have funds come in that can be used creatively. And again, I'm just so grateful that there was opportunity to partner with Alaskans across the state to envision what this looks like. That means there will be hard choices. Not everything can be done, but what does this 5 year look like moving forward? And grateful for your all time. Oh my goodness, my voice all of a sudden. Next slide, please. As when I worked at the department, the health, well-being, and self-sufficiency of every Alaskan is a great mission to roll off the tongue and to keep grounded in your vision and mission. And again, grateful for the team continuing to do that, but want to continue to lift up what the vision is for this project so that when we're thinking about sustainability, when we're paying for really the outcomes we want, we are doing it in alignment with this vision, ensuring that every Alaskan has access to affordable care to be healthy. And that includes access to primary care, prevention, close to home, making it easier to get mental health, specialty care, emergency care, long-term care services. And part of this, and I think hopefully what we'll dive into more both today and in future sessions, is what are the barriers that can be really reduced in the payment mechanisms and structures so that we're able to focus on patient care. I know as clinicians, that's something that both Dr. Rabinowitz and I think about a lot, and I know that many other clinicians are often focused on. And as patients, it's really burdensome and you spend a lot of your time trying to figure out the system. So what ways can we pay for systems that really respect patients' time and experience? So that we can really grow a workforce and communities that leverage technology and systems that connect patients to the services they need to be as healthy and well as possible. So moving on to the next slide, we are going to start to focus on this major section. I just highlight these are the three major goals within the Alaska's Rural Health Transformation Project. And to me, I think of this pay for value, fiscal sustainability as the base of it. I want us to be cautious not to think that we've got to jump to solve all problems at once, but how do we use this in a stepwise fashion to transform the system. I'm going to build a house. I don't just say I'm going to need a house tomorrow. I need some bricks. I need a plan. I need a roof. I need other things to layer on top of that. So thinking about how we can think about the bricks to build a system that ultimately pays for value through this time and effort. So going on to the next slide, we are going to start to dive in specifically onto this paying for value and fiscal sustainability. Back to you, Dr. Rabinowitz.
Perfect. And I think this voluntary shift from financial metrics really to patient-centered outcomes, focusing on long-term health improvements and sustainable care models is going to benefit the entire system. So traditional fragmented models are unsustainable for rural providers with these low patient volumes and high fixed costs. So let's talk about what we want to focus on today. We're going to start slow because much like you guys, my brain starts to hurt if I hear fiscal sustainability. I just turn off. So let's talk a little bit more about how we can ease into this. Today, we're going to focus on really recognizing and supporting value already being created. So better outcomes, better experience, and smarter use of resources. Sustainability, and we're going to keep talking about that throughout this session today, really ensuring providers and communities can continue doing this work over time, working to reduce fragmentation of care and creating a more accessible health system for everyone. And three, exploring the fundamental capabilities that build readiness for value-based payment models while acknowledging that this is a phased transition and it's going to take time. We have to prioritize preventative, primary, and community-based care as we kind of move forward. So when we're talking about value, what are we really talking about? And I think if we break it down to these three things, it's better outcomes and patient experience. It's really improving quality as we focus on the comprehensive needs of the patient, as well as improved provider experience. More time on patient care, less time on administration tasks. That's always a win. And then overall costs going down. As finances are stabilized and allow for sustainable funding in rural health systems, we can bring all those costs down. And then three, effectiveness and efficiency are increased. We can use things that we've been talking about for the last 2 weeks. We can use data and information to really identify gaps in care and proactively intervene to help these high-risk patients. Finding ways to partner and collaborate between rural clinics and hospitals and tribal health is going to create a more unified care network, acknowledging that the patient's needs are not met when we're not aligned with the current structure. And we can improve all these efficiencies by not having to navigate a payment process that really doesn't match with what we're providing. And next slide. So why focus on paying for value? Like it all makes sense, but why even go through the effort of this? It sounds clunky. How do we change things? But really, our current payment system creates a fundamental tension where payers focus on controlling total spending while providers are paid based on a volume of services. Providers may be delivering important services that are not reimbursable or recognized under the current payment environment. So doing the right thing for your patients can make financial sustainability even harder for providers and clinics, especially in rural Alaska. Low patient volume, high fixed costs, and geographic isolation, we've touched on this already, really limit rural providers' ability to generate sufficient revenue. So we need to make changes, and this is our chance to really focus on that. And next slide. We're going to turn this back over to Dr. Zink, who's going to start us off on this discussion, and she's going to remind everyone to please participate. This is where the fun happens.
Great. So yeah, this is where the fun happens. And I hear a lot, well, we don't have managed care in Alaska. We don't have a pay for value system. But there is so much paying for value that happens already across Alaska that we can build on and to being able to move forward. So there is a little hand raise function on the side, and the team is watching. And so would love to hear what work you're doing that's adding value and what ways you wish the system better supported that work. If you were like, I always used to joke, if you're a king or queen for a day, if you had one thing that you could change, like what would you change and what's working in the value space as a whole? And as you're thinking about that, and I see one hand up, I just do want to say that the team from the Department of Health is copying the chat with all of your great information and contacts so that that can be shared on the website that Dr. Rabinowitz had mentioned, and you should continue to check regularly. So when that is up, that is where additional information will be posted. So wanted to highlight that. But Teresa, I'd love to hear your thoughts.
Let's see, am I off mute now?
You're off mute. We got ya.
I'm Teresa Lyons. I'm the CEO of a mental health private practice based in Fairbanks, Anchorage, and Kenai. And if I could do anything, we've been running a fellowship program since 2017. We have been self-funding that, and it is a process of diminishing returns. We bring new and early career mental health clinicians in and work with them and help them develop their transition into a provider role. And reimbursements have dropped and dropped and dropped, and we are a small private practice, and we have been impacted horrifically by that. However, we have graduated 9, and of that 9, 7 of them are still in the state providing mental health services. So we're very excited by that and would love some support. We also are advanced practice, and 40% of us are going to retire in the next 10 years or less. And so we need a place for advanced practice clinicians to be able to make that transition. So yeah, that's what I would love. Thank you.
Teresa, I really appreciate that example. And as you saw earlier, we've got workforce, but I would love if you wouldn't mind continuing to stay off mute and help us to share and think about um, how having a strong workforce pays for value, or if there's limitations in finding these advanced practitioners jobs, helping connect that workforce to sustainability and paying for value. What are your thoughts there?
So in our experience in advanced practice in mental health, we cannot educate enough of us to meet the demand. So we need to attract from other states. And Alaska is a rough place to stay if you don't have good support. And so we've watched as people have come in, and we have nurtured through the fellowship their growth in connecting with the communities that we're in, and just watching them evolve into these magnificent providers that they never even could imagine themselves, and watching them integrate into the communities in ways that many of us did not even envision. They provide really competent care, and they love being where they're at. And
Thank
not
you.
just in the same communities, they move to different communities. A couple of them have left and gone back to their states, and within a year called me up and said, "We're coming back. We can't practice here."
Yeah.
So very exciting.
Thank you so much for sharing that. And as we continue to think about that, workforce is critical. Angela, curious on kind of your thoughts here. Angela Johnston, can you hear us?
Yes. Hello.
Perfect. We got you.
So I work in EMS, supporting EMS in my region, and there, every region has EMS support. So this is a situation where this is something that is not being paid for currently. There are not other participants in our healthcare system who are expected to provide services for free and to pay for their own training and everything. And one, we need to prove that EMS provides value to our rural communities. 2, we need to connect them into the rest of the overarching healthcare system. And 3, we need to find a funding structure. So I'm not sure that this saves money. It just shifts the cost to where it, I think, more rightly belongs. Thank you.
I appreciate that. And I appreciate you highlighting the fact that sometimes shifting where money is spent is as effective as reducing costs, because if it's getting better outcomes or reducing that burden on patients, it is an important thing to think about. Jeannie, it is great to see you on here. I know you have thought long and hard about this. Jeannie Monk, over to you.
Yeah, thanks. Yeah, I've been thinking about this for so many years. And just to kind of build on what the previous speakers were talking about, I think the healthcare teams are just essential to adding value. I feel like our traditional fee for service puts all the emphasis on playing the physician rather than looking at the whole team. We need community health workers, as you mentioned on the screen, health navigators, EMS, and I wish the payment system could support healthcare providers building those really robust teams where everybody is doing their part. Um, And we're not relying only on the physician to be there, but the whole team has value. And right now, those providers that are really working to build the teams, like Angela mentioned with EMS, they don't get reimbursed for many of those people. And so I think it is shifting who is getting, how we're being paid.
I really agree with that. And kind of like, what do you feel like is really working to pay for value? I'm just going to keep you on the hook right now because I think that there
Yeah,
are things. Would you highlight some things that you think are working that others could build off of?
I think some of the primary care home models are working where I think primary care clinics get a per patient per month um, payment in addition to the regular fee for service to allow them to support some of those team members who they can't bill for. So that's one model I think that's working. I think in other places in the country, there's things that are working, but we have volume problems in Alaska where we don't have enough patients in any given place that create challenges, but there are pockets. So I would say the per per member per month kind of incentive payments are working.
Yeah, Jean, I really appreciate you highlighting those for people to build off that. I kind of wanted to next jump to Jean Quinn. There's some bunch of comments in the chat box about maybe Alaska needs to think about ACO model. So appreciate those who have put that in that chat box. Jean, I know you've spent a lot of time thinking about this space as well as a provider. Maybe would you share your thoughts about what's working and kind of the landscape for Alaska?
Yeah, absolutely. You're able to hear me?
We got you. Yep.
Great. Yep. Hi, I'm Gene Quinn. I'm a cardiologist at Alaska Heart Institute, but I'm also the CEO of Envoy Integrated Health. We are a collaborative of physician practices, currently 40 physician practices that do exactly this. We enable practices to be able to participate in value-based care, mostly around building the infrastructure and the building blocks to be able to have these advanced payment models that pay for exactly the work that you guys are talking about doing in terms of keeping your communities healthier. I would share that there are many of these models that exist in the lower 48, and they're very successful, and people have been doing them for over a decade. Alaska has been a little bit behind, but these models do work here. So we created the first and largest accountable care organization here in Alaska with Medicare patients, mostly in Anchorage, but expanding a bit to the valley as well. And we were able to save 10.4% of costs, so save CMS $7 million in our first year while keeping quality high. Again, but this is really about building the infrastructure so that the things that we're doing to keep our communities healthier fit into the way that healthcare is paid for.
Yeah, I really appreciate you kind of highlighting that and the ways that the state is, again, into the question, is working that direction. And thanks to you and your team and Zoya's commenting, great to hear. So those who aren't aware, I want to turn to Sean Sylvan as well next. I think that you're really kind of thinking about this in a different location. Sean?
Hi, and this is Sean. From Kidney Link. We work with Alaska Dialysis as well as the Kidney Hypertension Clinic of Alaska in a program called CKCC. We've been involved in value-based care in Alaska for the past few years, and as part of that, we've been able to successfully drive pretty significant improvements in optimal starts of reducing the patients that crash into dialysis, reducing hospitalization in late-stage CKD and ESKD patients. And similar to Gene, we've seen significant success in this Medicare program. CMS recently published the 2024 results a couple weeks ago, and we saved over 11% in terms of total cost of care for these very high risk, highly vulnerable patients. And so we're very proud of the work that we've done on cost of care as well as improving quality. And I think, as we think about the opportunity, there's significant opportunity to expand that model to other patients that are not Medicare fee-for-service patients today.
Yeah.
Really excited about this opportunity.
So much work to be done there. Appreciate that, and love thinking about the ways that you and others kind of connect across the spectrum. I wanted to just a couple more little quick comments. I'm going to go ahead and call on Tyler. Tyler, I see your hand up.
Hello, are you able to hear me?
I am. Go for it.
Okay, so I'm a little bit different situation than most of you all on this call. My name is Tyler Vos, and my company is called Viridian Strategies. So we're seeking to help the Rural Health Transformation Program protect the integrity of the federal dollars that are being provided, the grant money, by building strong internal controls and program integrity analytics and practical fraud response plans. In my experience as a former FBI white collar and public corruption agent, we focused on healthcare fraud, white collar investigations, that type of thing. And we saw that value-based care in that world really delivers value when the money isn't misused or stolen. I know for a fact about nationally, an estimated 10 to 15% of all federal dollars in grants, healthcare expenditures specifically is the victim of fraud, waste, or abuse at about 10 to 15%. So, for
Yeah.
example, this grant, it's
Tyler,
272 million, right? We're talking
yep.
about 27 to 40 million.
I
So,
appreciate that. We're really going to try
yeah,
to stick on local data, and we will be providing, particularly to
right.
regions on that space. Would love for you to share more thoughts in your chat box about like we're really kind of trying to highlight what Alaskan kind of companies, but really connecting what
Right. I
Alaskans are
am an
doing.
Alaska-based company, and I
Great.
have a very specific question about this.
Yeah, and so we're really right now sharing what you're doing well. Is it questions about your specific projects are really served for TA sessions? So
Okay,
um,
understood.
yeah,
Understood. All right.
great. Sorry, there's so many great people on here. We really appreciate the work that you and others are doing, but the TA sessions are for any specific project. And I wanted to go ahead and move to the next slide because I want to continue to push us to really thinking about how we can continue to move forward. So one thing I wanted to highlight about the path to sustainability is to lay a foundation in the steps that might need to be able to get there. So how are we thinking about alternative payment models? And you're hearing lots of people thinking about it everywhere from like dialysis to ACOs to the ways that we're thinking about bundled payments. I wanted to raise up again the example that we had on community health workers and workforce as ways to be thinking about payment models and what Jeannie Monk did and shared about rewarding healthcare providers for delivering high quality and coordinated care and like the stepwise process to being able to shift to that process. And the objective is over time to transition these models rather than all at once. So again, I'm just really highlighting this road perspective, highlighting, navigating the payment rules, the use of data. Taylor just brought that up, like great data across from the Medicare space. But how do we really focus that for like, what does that look like in Utviadvik? How do we make sure that your region that may have Medicare patients, Medicaid patients, tribal health, and as Deputy Commissioner Ricci highlighted, has a really different payment model so that we make sure this is working for Alaskans across state and learn from great experiences across the country to add to this. Go ahead to move to the next slide, please. So as we're thinking about building these alternative models, I like to think about it in terms of kind of these four buckets as a way to think about the ways that we can put it in. So how do we navigate payment rules? Are there services you deliver that are clearly reimbursable in the coverage rules? What things could be changed to make that easier? Administrative solutions. Do you have workflow and staffing capacity to bill accurately and consistently for those services? I hear this all the time from community providers. 60% of who I care for are Medicaid patients, but it's really hard to figure out how to bill Medicaid. So I just don't do it and I just do it for free. So figuring out like who you can partner with, how can we like think about how to support that? As again, Taylor and others, I always go back to data. What's the data nationally? What's the data locally? So really kudos to the Department of Health, as well as some of the teams supporting. We had a great fun meeting with the public health team last night, thinking about how to use data to really support what you can understand in your regions to be able to use this to pay for value. Because if you don't have access to that data, it's hard to know where you're going. And then how do you really demonstrate that value long term in a way that is useful, productive, and can create sustainability? So now we're going to get a little bit to the fun part. So go ahead and switching to the next slide. I was teaching a class last night and I had them do the same thing. It's one thing to say you want something. It's another thing to have to make the hard decisions on what you're going to do. So we're going to go ahead and release a poll. And there is another component in here because lots of things went on and off in thinking about this. I want you to rank an order of these things that are out there. And if you were to pay for value and fiscal sustainability, what should the state focus on first? We're going to use this to both kind of pull you all and get a better sense of what's done. We've seen some people share great examples, but this will also help us to direct future conversations so that we can provide more TA support and more direct connection. So maybe there's people who are really using data to do this, or they're establishing administrative solutions so that you guys can learn from each other and go from there. So go ahead and rank and vote. And then once you're done and the team starts to see the numbers rolling in, we'll go ahead and close out the poll and see what people said. I'm sorry, Evan, you can only vote once, which is part of the problem. Let's see here. Okay. I'm seeing comments as well in the chat box, which you are welcome to share. Kira, I appreciate your comment about the power of providers have to address structural changes. You and Jean should go out for a cup of coffee as providers trying to change structural systems, but thinking about the ways. Sorry, Jean, signed you up. So once we go ahead and see this poll, we'll go ahead and release it. Jean likes coffee. There you go. I like coffee too, so he's all game. See, making connections in the chat box. Zoe also said happy to provide, or Ashley said she'd be happy to provide what Providence has done in that space. And there's also another offer for coffee. This is a coffee talk. So this is a little bit different than the last one. So you only got one, and that's what you got to rank as the highest that you think is most important. So what looks like is demonstrating value really came out as the number one, followed closely by payment rules, navigating payment rules, and establishing administrative solutions. So kind of it's great to see what's in there. Some comments in the 4 people said other, so always put those in the chat box. Always looking forward to those. And with that, I will go ahead and go to the next slide and turn it over to Dr. Rabinowitz. Oh, you're on mute.
Perfect. So we're going to continue this discussion. Again, please, let's get some hand raised and kind of talk about this some more. I'm really seeing a lot in the chat about the team approach. And I think we've talked a lot about this in these impact sessions, but really, as we demonstrate value, the team approach becomes key to this. And I think people that are already doing this have realized that. And I think there's a lot that we can learn from that. So if we could get some people chiming in on that. I know Jessica Downs is on today and wanted to share a little bit about the Community Care Hub and how they worked on setting it up to align with pay for value. So Jessica, if you could talk a little bit about that, that would be really helpful. I think you have to raise your hand first. Yeah, there you are.
Can you hear me now?
Yes.
Okay, excellent. Yeah, I had my hand raised and then Jean started talking and I put it down. I thought I didn't want Envoy to take too much time. But as Jean mentioned, Envoy is a clinically integrated network and an ACO here in South Central, but we are also piloting something called a community care hub. Community care hubs are kind of newer, even downstates, they're pretty new. But it's a new structure up here in Alaska that really sets to establish kind of a very formal and coordinated connection between our clinical systems and our community systems to make it easier for conversations between these two systems to be bidirectional, collaborative, and really most importantly, figuring out ways to make them financially sustainable or reimbursable. So we're early on, we're in the pilot phase now of kind of building this structure and this system, and we built it off of where we're at here in Alaska, which is a heavily fee-for-service structure. We're using some Medicare codes that allow for collaboration between the clinic and the community, and this Medicare code has a carve out for states like Alaska where we don't have a license for our CHWs. They allow us to, instead of having a license or a certification, to instead have a standard training requirement. And as long as we can show that our community partners meet that requirement, the codes can be delivered and the billing can be submitted. It's a bit of a unique structure even among hubs because the coding and billing still sits at the provider's office, but the community care services sit out in our community. But so far it's working. We're extending the hub. Right now we're focusing on elders with cognitive decline, but we're going to be extending for a bit of a modified transitions of care program where we'll be referring patients at the point of discharge to a community-based organization and then having them help get the patients back in for their follow-up appointment. We're excited for this transition to pay for value as it really incentivizes this collaboration more. Right now, a lot of the work and responsibility and the initiating and follow-up appointments sit on the clinical team, and there's a lack of incentivizing that collaboration and that service, but value-based systems really transition that conversation and support hubs and the community in a way that is financially sustainable even outside of, the onesie-twosie fee-for-service structures. It also takes away the limitations on the patients that we can see or what insurance they have to have or what other factors that kind of limit who we send through the hub. Changing to a more value-based structure kind of takes that limit away. So
I really appreciate you highlighting that and the great work that's being done. And I would love to also, if people are working in mobile integrated teams or other things, I think that's another really great example and kind of hits on the community worker. Would love to see it. And Jessica, you're getting chats in the chat box. Maybe you're getting coffee too. I also kind of wanted to pull out a couple other threads that I've seen in the chat. There's comments about construction needing buildings. CMS has been pretty clear that unfortunately these cannot be used to build a building. And so while that is a critical part, we know that these rural health transformation funds can't be used for everything, and we need to stay within the guidance of what Congress appropriated them for and moving forward. So there are other avenues that we can always partner with and think about, but really kind of staying within these funds is the effort. The other one that I wanted to raise up was fraud, waste, and abuse. As a provider, I want to make sure every dollar is used as effectively as possible. There's tremendous work happening at the state and the federal government to be able to make sure that, again, there is not fraud, waste, and abuse, but not really the focus of this rural health transformation dollars. But I wanted to turn it over to DC Ricci. I know you spend a lot of time, not just in the rural health space, but broader in this space to help kind of ground people in those conversations as well. Thanks.
Yeah, thank you, Dr. Zink. So, as part of my role in Deputy Commissioner, I oversee the different sections and divisions that make up the state's Medicaid program. And I think one area of agreement across the board is that the funds that are being used for the Medicaid program, but really for any publicly funded health program, should be used for the intended purpose. And, I think there is tremendous alignment from everyone on that goal and that purpose. And I'm glad that we're talking about it as part of this conversation, because I think to the point that was made earlier, as we're building these systems out, right, as we're thinking about how do you measure outcomes differently? What does accountability look like differently? You need to be thinking about how are we building in from the beginning metrics and billing approaches where we can ensure that those are being used in the way intended, right? And providers have clarity on that, and it's something that they can easily demonstrate so it doesn't become an access to care. But we can also make sure from the state side that we have the accountability that we need to make sure that we are guarding against fraud, against abuse, and against waste. And I think for anyone in the healthcare system recently, right, that really important focus on what we call program integrity or what we call fraud, waste, and abuse, there's an intense focus at the national level. And you're going to see that trickling through to states because, again, we have these shared goals of protecting against that. I know Alaska has stepped up our efforts probably really in the last 6 to 8 months, working in coordination with the Department of Law and taking some different approaches. And you'll continue to see that over the next few months and years as well. And as we think about technology too, technology and data analytics is so key. It's key to pay for value. It's also really important to use for identifying areas where fraud, waste, or abuse may be occurring. So I see some really important ties through this conversation, and I just wanted to acknowledge that, particularly as this discussion builds out at the national level.
Thanks so much, DC Ricci. And you spend a lot of time thinking about broad perspectives and why we really appreciate you all being a part of it. Back over to you, Dr. Rabinowitz.
Perfect. So if we can advance our slide, we're going to use one of our vignettes to kind of continue our conversation and get some more hands raised. So Tok Family Physicians, a primary care clinic in Tok, financial uncertainty shapes nearly every decision. The clinic depends heavily on fee-for-service payments that fluctuate with seasonal demand. staffing shortages, and patient travel disruptions. Leadership spends much of its time managing cash flow and must make difficult choices about delaying equipment upgrades and which services can be maintained. Limited margins make it risky to invest in care coordination, prevention, or workforce stability, even when these investments could improve patient outcomes. So Toke Family Physicians focuses on volume to keep the clinic open, while long-term planning and regional collaboration remain out of reach. So as we're thinking about Toke Family Physicians, what can we come up with as a group? How can we help them demonstrate their value? How can we use those frameworks that Dr. Zink brought us through earlier? How can we move towards paying for value? And if we could get some people to raise their hand and chime in, that would be great and get the conversation started.
And I think as people are doing that, I see comments about like how do you create a hub of support, thinking about Toke and thinking about that fee for service, what's needed in that space. And again, highlighting what may be working in places that could be shared, not to pick on Toke, but we tried to pick Alaska places that were but not specific Alaska, like this is the problem in Toke. So I'm curious on people's thoughts.
I'm also seeing a lot on quality metrics, kind of data, and I think that is a really important part to this and how we're going to demonstrate value, and again, how we'll find gaps in our services for our patients. So I think it's an important aspect to this, and building that in early on in this 5-year transition is going to help us get to the model that's going to serve us the best in different areas. I'm going to call on Piyama to come off mute and go ahead and share your thoughts.
Hi, I'm a private entrepreneur because the services that I am providing for are not provided in Unalaska. I'm from Unalaska. There has been no elder care services, and written into my plan is to promote entrepreneurship because I believe my business can't or shouldn't do everything. I could help people start businesses like care coordination, providing supplies, shipping, expediting services. These are the small things that business has to pay for in their operations that doesn't have to be their responsibility. Because we're going to be buying food anyway, we might as well help people start a business that could lower our costs.
So I think there's a couple important things with what you said. You said, I can't do it all. And I think we're really back to that, creating a team approach and figuring out how we can integrate and braid in with our clinics, our hospital, our tribal health, and make better value that way. I also think, in these really remote communities like Unalaska, it's going to look different than it looks in Fairbanks, in Tok on the road system. Things are just different. So how can we look at those different aspects of the state and create a different value approach while still being able to pay for these services and make it sustainable? So I think those are definitely things to think about. I'm going to call on Jason to share his thoughts, and then I apologize, Ashley Thoreau has put some nice comments in the chat. And so if you could also consider raising your hand and coming off chat after Jason, that would be great. Go ahead, Jason.
Thanks, Lisa. I actually was going to build off of Ashley's thoughts. I thought that they were really good, talking about the importance of getting this data to providers. And we're a clinically integrated network, Alaska Provider Network, primarily in the Valley in rural Alaska. And what we found is that it becomes really difficult for providers and clinicians to have to go to multiple places to get all this information, different systems. And so for us, we've chosen to put all the information back in the EMR so it's at their fingertips. So we're taking claims data, remote patient monitoring data, real-time social determinants of health, clinical data, and we're marrying it together. And that's allowing providers to see what they need at the point of care. And we can send alerts to them, and we can take action on discharges. And using that same data, then you can use predictive analytics and identify high risk, high cost. So no matter where the patient is, or where the provider is, we can get that data in a meaningful way to them, so decisions can be made rather than they having to go to all this disparate sources to gather that information. And we find that's allowing us to make big strides in our value-based contracts, both in commercial and in Medicare contracts.
That's outstanding, and I think that's exactly what we're kind of envisioning as we're thinking about moving forward. And it's really improving that patient experience and also the provider experience, allowing better utilization of the data to inform health choices for your patients, and then having the time to actually sit down and spend time with the patient. So I appreciate that. And go ahead, Ashley, and come off mute and share your thoughts.
Hi, can you hear me?
Yes.
Yeah, thanks for inviting me to make some comments. Just, kind of reiterating what I put in the chat. I think for a lot of these rural clinics, they know their communities really well, right? No doubt. And but I think that the ability for those clinics to have access to data of, who are all the patients in the community, and could a proactive payment be made to that clinic that would incentivize them to get them in, even providing contact information, right? Sharing that information between the state for the Medicaid patients and with Medicare, with CMS. That way the clinic has, a sustainable payment model that allows them to keep their doors open, while then incentivizing them to reach out to patients. And ultimately, and that's sort of the premise behind value-based care, right? You get those patients in, you proactively manage them, and the state and CMS would see that savings occur on the back end, because of the reduction in utilization of those patients and just better management of their chronic conditions.
Yes, absolutely. I think one thing I appreciate about your comments is really highlighting each area is so different in Alaska, and what makes sense and how that integrates is going to look a little bit different, and finding ways to do that. I think, Jessica, you had some specific thoughts to kind of dovetail onto what Ashley just said. So if you could just come off mute and share a little bit more about your comment, Jessica Downs.
Can you hear me now?
Yes.
I was like, me, Jessica? Yeah, I guess I just was gonna comment that a clinic like Tokes could really benefit from an alternative payment structure where clinics, through a variety of different methods, but get to keep the money they save, if that makes sense. Some of it is, by getting a kind of a lump payment for their patient population. Others, it's by calculating the total spend versus the average spend. There's different ways that they work, but what it does is it generates money that is, for lack of a better term, otherwise unencumbered. It's additional savings that come back to the clinic. So the clinics are incentivized to do things that maybe don't fall into a traditional billable structure. For example, partnering with the community care hub to use community health workers or community-based organizations to render services that don't fit traditionally billable, but do improve the health of their community and decrease the cost. Things that are keeping our patients out of the ER, things that are keeping our patients healthier, the work that comes into helping our patients navigate the community care system, housing, transportation, childcare, all the stuff that's keeping our patients from accessing healthcare. If we can contract and use some of that shared savings, some of these otherwise undesignated funds, to do things like that, then it both creates additional, revenue for the clinic. It keeps our patients healthier. It allows for services to be, a little bit more patient-centered, culturally appropriate, and customized, without the dependence on a fee for service where you have to have a specific provider type performing a specific service in a specific geographical location with a specific code tied to it. A lot of that can fizzle out when it becomes more about customizing the services to keep your patients healthy and less about meeting a definition that makes billing fee for service limiting and complicated.
Thank you very much. I think the way you said that makes it seem very simple and doable and calm. And so I definitely appreciate that sentiment. We're going to move on to the next slide and briefly talk about how we've transformed Toke family physicians. I think we've talked about some of this work today, but really, as Jessica said, making sure that our services are reimbursable under the current payment and coverage rules, and streamlining administrative tasks and billing, building capacity to manage population health. So really working towards primary and preventative care, and investments in data infrastructure, technology, and team-based staffing. So really working towards that team approach, and expanding those management care teams. I think we have done a lot to work on building this across Alaska already. We've seen a lot of grassroots in the chat on people piecing things together to make it work. But I think if we can build these frameworks that Dr. Zink kind of laid out, our 4 frameworks in the beginning, that's how we're going to build this over these 5 years. And so we're going to move to the next slide, and I am going to throw it back to Dr. Zink to kind of start our wrap up on this topic for today.
Yeah, seeing so many great things in the chat box and just really appreciating the engaging conversation. There's lots of models that CMS and other states have used that are being put in the chat box. I know the state has been considering them and looking at them for years in all sorts of different ways. And so I'm always, excited to see people engaging and understanding what's happening, seeing a lot of conversations about what's happening with data and community health center programs as a whole. I really appreciate people bringing up this kind of stuff about, TA support and back office administration solutions, as well as data that's needed to be able to share there. So I think those are topics that we can explore together. Like, what data is really needed? How can we do it? What does that look like? And we heard, EMR solutions, and what ways can we use the HIE, claims databases, making Medicaid data more available. We live in a world where that's changing all really fast, so that we can really explore these CMMI models. You see on here, like the head model, care models for dual eligible patients, regional care coordination. Many of you have highlighted many of these things, as well as TA for support. I think my favorite thing, go ahead and go to the next slide, of the conversation was highlighting many of the things that were summarized and already being done within the state of Alaska. I just hear the conversation a lot. We don't pay for value. There has been a long and progressive trend in that direction, and we have a lot more work to do, and appreciate the partnership with you all. So that I'm going to hand it back over to Commissioner Hedberg to close us on out.
Thank you so much, Dr. Ann Zink. Man, our time flies, and you can see the passion and interest in this impact series. So this is a summary of the impact sessions. There will be a recording and summary posted on our website. Next slide. Here's a QR code. You can scan it. It will go directly to our website. Next slide. And if you have questions as a follow-up, I really encourage you to email our general inbox. It is staffed, and we want to make sure that your email doesn't get buried, which is why we created that general inbox. We continue to update our website. So if you go to our website, click on the sign up for RHTP updates, you'll be noticed every time we update our information. I really appreciate everyone's participation in this conversation, and we will see you at our next Impact series. Take care, everyone. Bye-bye.